Next, we have Dr. Sumina Jabbar, who will be talking on effect of refractive surgery on binocular single vision and ocular alignment.
Good morning all. My topic of presentation today is the effect of refractive surgery on binocular single vision. My topic of presentation today is effect of refractive surgery on binocular single vision and ocular alignment. I have no financial interest. So some of the patients who are undergoing refractive surgery may have a doubt what will happen to my squint if I undergo refractive surgery. So we know that the refractive surgical procedures help patients with refractive error to achieve spectacle independence. But apart from addressing this refractive status, it can address the binocularity of the patients also. These surgeries, these refractive surgeries can have a positive and a negative impact on binocularity. That is, these refractive surgeries can help some of the accommodative deviations and mild anisometropias can be managed effectively with refractive surgeries. But in some patients, postoperative binocular decompensation can also occur, and this usually occurs in patients with those having pre-op binocular vision issues. The most common reported complaint of binocular vision abnormality after the refractive surgery is the reduction in fusional vergence. Some patients complained of postoperative haze and diplopia after the refractive surgery could be due to these binocular vision abnormalities. So a thorough preoperative evaluation of binocular status is essential in all patients undergoing refractive surgery. Moving on to my study, it's a prospective study of 42 patients who underwent refractive surgery from a time period of April 2024 to June 2024 and with a follow-up period of 3 months. We did a complete ocular examination including cycloplegic refraction, and we assessed the binocular status using Worth dot test, stereopsis by Rantot, cover test, alternate cover test before and after the procedure. We also assessed the type of refractive procedure the patient underwent. Moving on to the result, in our study, most of the patients are females, that is 64.3 are females and 35.7% are males, and the age group ranges from 18 to 34 with a mean age of 24.6. That is, most of these patients are in either students or in a productive age. And 84% of the patients underwent LASIK surgery, 16% underwent LASIK surgery. All patients in our study who underwent surgery were myopes. None were hypermetropes, and with an average spherical equivalence of minus 3.4 diopter sphere in the right eye and minus 3.2 diopter sphere in the left eye. Among 15 patients who underwent, who has a preoperative exophoria for near, preoperatively, 12 patients continue to have this exophoria for near after the procedure, while 3 patients exophoria resolved. And in 10 patients who were orthophoric for near before surgery, developed exophoria for near after the surgery. We have a patient with intermittent divergent squint with good control before surgery, and he continues to have this intermittent divergent squint with good control after the surgery also. And vision improved to 6/6 in all patients in our surgery. Fusion and stereopsis were maintained after the surgery in all patients. In our study, none of the patients developed manifest squint after the surgery. So moving on to discussion, refractive surgeries can have a positive and a negative impact on binocularity, as by correcting the refraction, mild accommodative squints and mild anisometropias which can cause binocular vision abnormality preoperatively can be addressed by these refractive surgeries. But these refractive surgeries can cause diplopia and other binocular vision abnormalities, like these surgeries can cause monocular diplopia due to decentered ablation and binocular diplopia due to the decompensation of foria to large topias postoperatively. And some of the refractive surgeries aiming at monovision with high anisometropy of more than 1.5 diopter can precipitate these binocular vision abnormalities. So in this small study of myopic patients who underwent LASIK and LASIK surgery, majority of the patients with exophoria for near continue to have exophoria after the procedure, while in 3 patients exophoria resolved. One finding is that 10 patients who were orthophoric before surgery developed exophoria for near after surgery despite a normal near point of convergence. This could be due to a sudden change in the accumulative effort need to be activated for near vision. So orthoptic evaluation and long-term follow-up should be done in these patients to assess whether exophoria improves or it decompensates to exotropia. In our study, a patient with intermittent divergent squint with good control before surgery continue to have this intermittent divergent squint with good control after the surgery. But there are reports which shows that Mandava et al. Reports a case who developed diplopia due to decompensated exotropia 9 months after a refractive procedure. Schuler et al. Reported a patient with vertical and torsional diplopia caused by decompensated congenital superior oblique palsy immediately after a LASIK surgery which aims at monovision. Yap and Kowal describe a patient who presented with exophoria preoperatively, developed vertical diplopia and after LASIK surgery that was decentered. The limitations of my study, we included only patients underwent LASIK and LASIK. Other procedures are not included. We have only myopic patients, no hyperopic were there. And the short duration of study, small sample size and short-term follow-up, because follow-up is essential to know the cause of these errors. So, significant binocular vision abnormalities are not noted in our study, but a thorough binocular vision evaluation preoperatively and postoperatively is recommended in all patients undergoing refractive surgery to avoid postoperative surprises. Thank you. Thank you.
Next we have Dr. Remy Singh.